We're going to spend the next few minutes in our panel talking about the what. So the evidence for change, what we understand, making the case for a Newcomer Health Plan. And we're going to have three presentations. So I'm going to invite in a moment Duberlis to start, who will give us the grounding, a statement of intent of what we're doing and why we're here. Salima Alana will give us some case studies and some scaling, some of the evidence based on some of the research you've seen, some of the promising practices that, if scaled, could be very impactful and have more positive outcomes for newcomers. And then AKM Alamgir from Access Alliance will provide us with a bit of a narrative transition to the second panel. And that second panel will talk about moving from just consultation to co-ownership. And I'll explain a little bit more about what we're going to do when we get there. So without further ado, Duberlis, I'm going to turn it over to you, and please jump in.
Well, thank you very much, Marco, and good morning, everybody, and thank you for being here. As Executive Director of the Hispanic Development Council, Community Worker, Development Planner, and Cooperation Practitioner, I would like to start by declaring my commitment and that of our partnership led by Access Alliance to seek the cornerstone objective for this initiative to achieve the enshrining in Ontario's health system of a new, equitable, and sustainable approach, securing a newcomer health plan focusing on recognizing current and longitudinal newcomer populations in their right to access health services to achieve their best health potential, so to be able to contribute and enjoy life opportunities in our province and Canada, meaning no more barriers for newcomers to access our health services. It is clear that we cannot change the past regarding unmet outcomes. However, this is the time for all of us to transcend this with unified vision towards a much needed new and fresh health social justice model, co-designed and shaped by the empirical evidence born from our experiences in community building, new knowledge, research, firm intentions, values, and ethics. The call is for all of us together in 2026, mindful of the fact that we need ethically to avoid pseudo engagements. It's one of Achilles' heels in some instances. Let's think of this as a collective contribution to building this socially co-designed equity model to which some of us have been dedicated to for decades. Yes, there have been changes. However, we could have done better. So today we are looking forward, building a new model inspired by history and our capacity to transform this project into a movement to ensure newcomers equitable access to health services always. Since my arrival to HDC in 1992, it was clear that Access Equity Health agenda was always an imperative to the diversity of our many communities and getting to our city, carrying with them stories of survival and horrors, but hope as well, with entire families needing both mental and physical health. In the 1990s in Toronto, we experienced HIV/AIDS. At the same time, the Central American refugees wave was arriving in Canada with many health challenges as a result of wars and turmoil in home countries. Locally, in Toronto, in the late 1990s, hospitals were also dealing with the institutional issues of governance, amalgamation, the new city, and hospital reform, with the corollary of SARS in 2003. This impacted the newcomer community with confusion, fear, and a sense of defenselessness, and the obvious what to do about it. Notwithstanding all these disruptions, with the Canadian Chinese National Council, CTO, Council for Agencies Serving South Asians, and our own HDC, Hispanic Development Council, we came together as the Alternative Planning Group, APG, to challenge conventional practice through changing the paradigm. That was our motto for an inclusive Toronto, focusing on our diversity in the setting of public policy goals for the most vulnerable members of society, newcomers, and equity-seeking persons. Since then, the community, at least in our perspective, is a subject. We are not the object of public policy, especially in the health area. It must be noted also that SARS and SARS victims included hospital workers whose knowledge and lived experiences should also inform this project. COVID-19 also left us with some similar feelings because a number of our victims were health workers, nurses, and regular people in very high numbers in the case of the Latin community here. Colleagues, we still have lots to talk about systemic experiences and systemic change. We need a change, of course. Today, health equity and mental health have rapidly become key boundaries also to be addressed by our collective work. We have a crisis linking immigration and settlement problems in addition to pernicious poverty, pernicious poverty among many newcomers. And illustrating a perspective from a young person in our counseling program. A year ago, this person tells us, I face ongoing challenges with thoughts of suicide, experiencing memory issues, a struggle to find motivation, difficulty managing anger, battling depression. From another perspective, emotionally, witness parent separation, endured prolonged bullying for years, dealt with family distress due father's cancer diagnosis, took refuge in a shelter to escape abusive conditions. And from an immigration perspective, as she puts it, challenges and isolation growing up as the child of immigrant parents in Toronto, navigating healthcare and personal affairs without parental linguistic support. This young person is now pursuing an undergraduate degree in psychology. In conclusion, this initiative must transcend the limitations of temporary grant-funded projects and focus on possible points to explore further, plus others emerging from this session, of course. We need to consider building momentum by declaring intentions and inviting broad participation from the community sector, academics, and government to build together this transformative social movement by sharing knowledge and skills to change health inequities, opening our minds to new thinking and new ideas to accelerate broader inclusion of newcomers, but also other community actors with know-how interested in advancing the common good represented by health as a symbol of progress. We should notice that we face a change of times and attitudes and values are also in evolution. So we should think of that. Recognizing the resilience of many of our grassroots communities bring us back to learn as well from their and our own lived experiences. Hence, building the Newcomer Health Plan should be a community mobilization project movement right from the start to maintain commitment regardless of immediate community funding outcomes. In the least, this idea will impact social cohesion and enhance health from the fringe. Exercising our collective ethics in this project, grounded in a 30-year history of advocacy and shared sense of responsibility, provide us with certainty that our own collective values should provide communities with a first line of support during conflict, disasters, uncertainty, or unforeseen events. In other words, we must strengthen in the process our resilience, which have brought us collectively here, at least at the community level. So, having said this, I just one last thought very quickly, because I was thinking in one of the areas that we must think, and is the government participation in this. At times, seems it is difficult to work with governments. However, I think in this case we should consider that idea because, in thinking about it, governments have the same intent and interest of all of us in terms of bringing community health status to a better level always. And we think that they mean well in the process. So, having said that, why couldn't we as well put a little bit more emphasis as well in bringing people from the government to work with us as part of this collaboration so that we can together put some new ideas on the table and create further buy-in for these uh, very significant ideas at this point in our local history, and needless to say, today as well, regarding the entire world we live today. Thank you.
Thank you so much, Dualis, for getting us started with what it is that we're here for and how the collective action that we need to take is going to make us stronger in this. I'm going to invite Salima to join us. I will share your slides in a moment. So Salima is going to focus a little bit on how we can link academic research and other research with successful practical interventions and success stories to help move things forward.
Good morning, everyone. I am a health equity researcher, and so this work is very close to my heart. And I'm thankful to Duberelis for such a great grounding, after which I think we should get going on this journey of understanding why a newcomer health plan is needed in Ontario. Okay, so before we delve into the specifics of the newcomer health plan, I wanted to reflect on how newcomer health initiatives have traditionally been implemented in Canada and in Ontario. We see that historically most efforts in this space have been small scale and community driven, and these have been often led by either community health centers or settlement agencies. But these efforts have been incredibly impactful in addressing language barriers, cultural barriers, system navigation challenges, and other broader social determinants of health. However, we have also seen some consistent limitations in these models. First of all, many of these programs historically have been grant funded, which means they are time limited, and when funding ends, these programs may not continue. They're also geographically bound, so a newcomer in one region might have access to culturally tailored care, while someone in another region may not have access to the same supports at all. And thirdly, these efforts are frequently not formally integrated into the healthcare system. They exist alongside the system rather than being embedded within it, which creates fragmentation and makes it difficult to achieve consistent, equitable outcomes across populations. So, what we are seeing here is a disconnect between what we know works at the local level and what is implemented at the system level. And this is where the shift towards a provincial level approach becomes critical. And moving to a provincial mandate means these successful models are no longer optional or dependent on individual organizations. Rather, they become part of a standardized care across the system. And there is accountability for implementation and outcomes. It also means we move from reactive short term solutions to proactive system wide planning for equity. And most importantly, this is not about replacing community led efforts. Rather, it's about learning from them, strengthening them, and scaling them in a way that preserves what makes them effective. So the goal is not just expansion to a provincial level, but intentional equity driven integration at the provincial level. So before we talk about scaling our, existing models of newcomer health, I think it's important to take a step back and understand how the Ontario's health system is structured, because this directly shapes what is possible in this regard. So at the highest level, we have our Ministry of Health, or Ontario Health, which is responsible for setting policy directions, determining funding priorities, and establishing system wide strategies, including equity related initiatives. At the regional level, we have OHTs, which are Ontario Health Teams, that are designed to bring together different providers within a region, improving care integration and coordination. And these OHTs sit at the intersection between policy and practice. At the local level, we have where care is actually delivered, right? So at the hospitals, primary care providers, community health centers, and settlement and community organizations as well. These are the spaces where many of the innovative, culturally responsive models we are talking about are actually developed and implemented. In parallel, we also have public health units which focus on population health, prevention, and community level interventions. Now, the challenge and the opportunity is that these different levels often operate in silos. We have a strong local innovation and we have clear provincial priorities. But the issue is that these are not always connected together. Scaling in this context is really about creating alignment across these levels. It means ensuring what works locally can be recognized at the regional level, supported at the provincial level, and implemented consistently across the healthcare system. It also means ensuring that community knowledge flows upward and not just that policy flows downward. So, right now, when we are talking about a provincial mandate or a provincial level newcomer health plan, we are really talking about embedding the successful models that have been tested in the past into policy and funding structures, and leveraging Ontario health teams for regional implementation and supporting local organizations to deliver culturally appropriate care at scale. With that structure in mind, I think the next question becomes, why is it so important that we focus on scaling what already works rather than creating entirely new solutions? So, I believe that a core principle of this work is that we should not be reinventing the wheel. Rather, we should be building upon what has already worked at the local level. So, over the past several decades, a significant amount of work has already been done to develop approaches that are effective for newcomer health. These models are often deeply rooted in communities, they're culturally responsive, they're built on trust, and they're designed to address the specific barriers that newcomers face when accessing healthcare. However, despite their effectiveness, many of these models remain small in scale. They are often limited to specific organizations or regions and are not systematically adopted across the broader healthcare system. I think when we continue to create new solutions without building on what already exists, we risk duplicating our efforts, wasting resources, and missing opportunities to expand approaches that have already been proven to work. Scaling, on the other hand, allows us to take what is already effective and to amplify its impact. It enables us to move from isolated pockets of innovation to broader system wide improvements in equity. It also helps ensure culturally appropriate care, which is not dependent on geography. At the same time, it's important to emphasize that scaling is not about simply copying and pasting a model that worked in the past into a new context. Rather, it requires thoughtful adaptation. With that in mind, I'll now walk you through some examples of some of the past successful models in Newcomer Health. So, the very first example that you see on the screen right now is that of a model that uses community health navigators, which are also referred to as patient navigators. These are individuals who help guide patients through the healthcare system, particularly during complex transitions, such as moving from hospital care back into the community. Now, there's strong research evidence supporting the value of patient navigator role. For example, a study conducted by Cocorelius et al. 2021 in Toronto found that patient navigator programs can improve care integration and patient experience by helping individuals better manage their care and by navigating complex healthcare systems. This study also highlighted that these programs are particularly effective in addressing fragmentation between hospital and community care, which is a major issue for populations with complex care needs. Most importantly, the research identified several factors that make these programs successful, which include strong leadership support, effective communication across care teams, and existing partnerships between hospitals and community. However, despite this strong evidence, these rules are often implemented in a very limited way. They tend to be tied to specific programs, populations, or regions rather than being integrated across the healthcare system. So, at the provincial level, this could involve standardizing the navigator role, embedding it within the healthcare teams, and ensuring dedicated funding so that all newcomers, regardless of where they live, can benefit from this type of support. So, the second example that I wanted to share with you is that of culturally tailored digital health tools, particularly those designed with and for immigrant communities. As healthcare systems increasingly rely on digital solutions, these tools have the potential to significantly improve access to care and support self management of chronic conditions. However, despite this potential, there are important gaps in how these tools are designed and used, specifically for newcomer immigrant populations. A study conducted by Hyman et al. In 2022 with South Asian communities in Canada found that many individuals face significant barriers to using digital health tools. These include language barriers, limited digital literacy, and challenges understanding medical information. Interestingly, many participants expressed that they see clear value in digital health tools because they recognize their convenience, their ability to provide health information, and their role in supporting independence. This tells us that the issue is not a lack of interest, but rather a mismatch between how these tools are designed and the specific needs of the populations they are meant to serve. So, the key takeaway here is that digital health tools must be both technologically effective and culturally responsive. At a provincial level, this could involve embedding culturally tailored digital tools into standard care pathways while also investing in community based training and support systems. Without this, there is a real risk that digital transformation could actually widen health inequities rather than reducing them. Okay, so the third example that I wanted to share with you is that of another successful model of mobile and outreach based healthcare services. These models shift care from traditional centralized settings like hospitals and clinics into community spaces where people already live, work, and gather. For many newcomers, accessing care is not just about availability, it is also about accessibility. And barriers such as transportation, work schedules, childcare responsibilities, as well as unfamiliarity with healthcare environments can make it difficult for them to engage with the system. Mobile and outreach clinics are designed to address these barriers directly by bringing services closer to communities. Their key strengths is that these reduce both structural and social barriers to care. It allows individuals to access services in environments that they feel more familiar and culturally safe in, which can significantly improve patient engagement. However, similar to the previous examples that I shared, these initiatives are often implemented at a small scale. They may operate in specific regions or be tied to time limited funding, which limits their long term impact. And scaling this model at a provincial level would mean recognizing that outreach care is a core component of the healthcare system rather than an add on. This could include formal funding for mobile services, integration with Ontario Health teams, and partnerships with community organizations to ensure consistent delivery across regions. So, the fourth example that I wanted to bring up is that of language and interpretation services. From a research perspective, there's a very strong evidence showing that language barriers are a major determinant of health inequities. Research also shows that professional interpretation services improve clinical outcomes, reduce medical errors, enhance patient satisfaction, and support informed decision making. However, when we look at how these services are actually implemented in practice, we see a very different picture. Across Canada, and particularly in Ontario, interpretation services are often fragmented and inconsistently provided. Rather than a coordinated system, access often depends on the specific hospital, region, or organization, leading to significant inequities in care. At the same time, there are strong examples of successful ground level interventions that demonstrate what works. These models allow providers to quickly connect with interpreters in hundreds of languages, improving both efficiency and quality of care. Despite these successes, I think we still have important challenges. One major challenge is the lack of sustainable and centralized funding. Many programs rely on local budgets or short term funding, which limits their ability to expand. There are also operational challenges such as delays in accessing interpreters, variability in training, and limited integration into routine care. I think the next step for us is to move towards a more coordinated system level approach where interpretation is embedded as a core component of healthcare delivery across the province. Another example, and the last one, is that of settlement organizations having working in partnership with healthcare organizations. So, we all know that settlement organizations play a key role in improving access to healthcare for immigrants and refugees. These organizations often act as connectors between communities and the health system by providing referrals, health education, and navigation support. What makes these partnerships particularly effective is their ability to address not just the health needs, but also the social determinants of health. Settlement organizations support areas such as housing, employment, and language, which are all directly linked to health outcomes. A really strong example of this in practice comes from intersectoral initiatives implemented in Toronto during the COVID 19 pandemic. A key success factor identified was the role of community based organizations. At the same time, these initiatives highlighted several important challenges. One major challenge was fragmentation across sectors. Even though partnerships existed, services were still often siloed, making it difficult to provide fully integrated care. There were also challenges related to funding and sustainability. Many of these initiatives were supported through temporary funding during the pandemic, which made it difficult to maintain those over time. In addition, coordination across multiple organizations required significant effort. So, this example clearly demonstrates that settlement health partnerships are highly effective in improving access to care and addressing broader determinants of health. However, it also highlights that for these models to be sustained and scaled, they need to move beyond temporary, crisis driven collaborations towards more formalized, system level integration with stable funding. So, having seen these examples, there are a few key lessons that we learn out of these models that have been successful in the past. First of all, community engagement and co design are essential. The most effective interventions are those that are developed with communities, not for them, like without them. Secondly, cultural and linguistic relevance is a critical factor. Programs that are tailored to language, cultural norms, and health beliefs are far more effective in improving engagement, trust, and health outcomes. Third, trust plays a central role across all models. Many of the successful interventions rely on trusted community organizations or individuals who act as bridges between the healthcare system and newcomer populations. And lastly, integration across sectors is key. The most impactful models do not operate in isolation, rather, in collaboration. Okay, so what do we need for scaling these models at a provincial level? So, scaling requires standardizing successful models, it requires system level alignment, including policy support, stable funding, workforce training, and accountability mechanisms to ensure that equity focused interventions are implemented consistently across the healthcare system. Another important lesson is that sustainability remains a major issue. Many of these interventions are supported through short term or project based funding, as I said before, which limits the long term impact and scalability. So, we really need sustainable funding for these models to be scaled at the provincial level. Okay. So, one of the important considerations in scaling these models to the provincial level is ensuring that they align with existing provincial efforts rather than creating new or parallel systems. We all know that Ontario already has several major initiatives focused on health equity, which provide a foundation for this work. So, for example, the Black Health Plan, which was developed to address systemic anti Black racism in healthcare and to improve health outcomes for Black communities across Ontario's. Though it is centered on Black health, the broader approach is highly relevant to newcomer populations as well. So we have lots of lessons to learn from there. The second is Ontario Health's Equity Framework, which provides system wide guidance on how to integrate equity into all aspects of healthcare delivery. And the third is primary care attachment plans, which focus on connecting individuals who do not have a regular primary care provider to appropriate services. This is a critical issue for many newcomer populations who often face challenges in accessing consistent and continuous care. So, the question now is, how do we align the models we discussed earlier with these existing efforts? So, we talked about community navigator models, which can directly support primary care attachment strategies by helping newcomers connect to providers and navigate the system more effectively. We also talked about culturally tailored digital health tools and interpretation services, which align closely with the equity framework by improving access, reducing language barriers, and supporting inclusive care. We also talked about outreach and mobile care models, which can be integrated into both equity focused strategies and primary care initiatives. And then lastly, we talked about the settlement health partnerships, which are perhaps the strongest example of alignment. These partnerships already reflect the principles outlined in the equity framework and the Black Health Plan. And we can certainly use these to scale the already existing initiatives. So, to conclude, I think we need to understand that now is the time to act and create a provincial level newcomer health plan and to work towards improving newcomer health outcomes. Rather than creating entirely new programs, this approach will allow us to build on the existing infrastructure, policies, and momentum within the system. Thank you.
Thank you very much, Salima. I want to turn it over. Hey, KM, you've got 9 minutes, but you can take an extra minute or two to pull our threads together and lead us into the next panel.
Thank you very much. Welcome, everyone. I see many faces who patroned and nurtured the efforts of Access Alliance. That way I work at over the years on newcomer health plans, newcomer health activities like newcomer at workplace, newcomers during the COVID art-based approach, newcomer in settlement, newcomers in measuring health equity, all those. Thank you, everyone. It's a privilege to join here and host this panel series on newcomer health plan. It's very timely. Like is working on newcomer nearly 40 years now, for taking care of primary care, for taking care of settlement care, for taking care of language care, for taking care of navigators through Open Door project. We are working. And as Duberlis says, this is the time to concentrate our work, to transform our efforts, our project to a movement, a community engaged, a social movement integrating the academia, the policy planners, the government. I see people from the government here, and the community at large. This is the time. That's why we are here. And as Selima said, there are many efforts. We are not new in this field. And this discussion is not new, but all efforts are fragmented, siloed. Now, this is the time we can compile those efforts, co-design those to make a comprehensive movement, social movement. As earlier speaker said, newcomers are more a settlement connotation than a time attributed stay in Canada. And that includes residents from a wide range of immigration categories that Access Alliance serves. They may be landed immigrants, they may be displaced people, refugee or refugee claimant, people without any status, and international students, or others. And every community, every group has a unique need, but they have a common need, that we need a fair health care. That is the need they want. And as Selima said, the government has the intention, academia has the evidence. Now this is the time to compile and scaling up all those. So I go there. Health is a settlement issue, and settlement is a health agenda. And language is a true health determinant. That is my key point, that we cannot segregate settlement activities from health activities, health efforts, and health efforts from settlement activities. And mediator, the switch between these two, is language. That is the key potentiator. We have a paradoxical expectation and experience. In Ontario, we say that our health system is universal. Our healthcare system is universal. Exactly. We mean that. We want that. We desire that. But what the newcomer feels, they feel it is conditional. They feel it is fragmented. It is difficult to navigate or delayed. So we cannot guarantee a universal health system that is conditional, delayed, fragmented, or difficult to navigate. Reflecting on my early days in Canada as a landed immigrant, I had the opportunity on the day one to get my kids to school. I had the opportunity to get job, but I did not have the opportunity in Ontario to get a health card. I had to wait. I had to wait for an uncertain health journey. Anything may happen that I have to cover myself. There is no insurance around that. So that is a broken promise. Now we have to fill out the gap. Mental health is a quiet crisis. It's like a white elephant in the room. We perceive it, but we cannot see it, and we don't work for it. I call it a quiet crisis. And to the newcomer, it is not only about treatment, not only getting treatment only, but also about understanding the system of treatment, system of healthcare, for getting a family physician, for getting a healthcare journey, ongoing healthcare journey. It is about trust that Selima highlighted. It is about trust. It is about health with dignity. I am not a parasite when I am a newcomer. And it is about my safety. So we try to, at Access Alliance, we constantly work on it. And we try to find the nuances and blind spots. One point that I can identify that there needs a continuity of care between public health and acute care. Recently, Kai prepared 10 indicators for public health systems in Canada. But that is not integrated with acute health care. There are some missing points. Newcomers are not there. Senior health are not there. And 2 days before WPP Toronto, they published their report and told that research-based, it is a mixed method research-based data, 87% of newcomers feel discrimination. It is not a good news. 87, nearly more than 3/4 of the newcomer feel discrimination. It is perceived discrimination. So we need to build trust on them. So what should be the change? In addition to what Duberly said, Selima said, I need to give emphasis on when we make a plan. Today we'll decide, we'll make a group in the panel to co-design that a portable immediate basic coverage for everyone, every resident, because newcomer health matters. Newcomer health affects others' health. Newcomer health affects hospital economy. Newcomer health care affects emergency waiting time system. So it matters. So it should be expand community health model that Selima said. We have started Open Door and it is successful, and Ruzanra is here, so we are working on it. We need to have more research on newcomer at workplace. Dr. Boshaki Anar is here. We need to work more on that newcomer at workplace, newcomer at their home, and Open Door. Invest interpretation and navigation. Navigation. A healthy navigation, affordable navigation, and trustworthy navigation. And better data. We have data. We have to this the time. We have to use data. Finally, a newcomer health plan is not a charity. It cannot be a charity. We are not doing anything that we are helping them from that they do not deserve. They deserve this care. It should be a smart public healthy policy, very much intentional to support health of the Ontarians. And in the second panel, we'll discuss about the 5 key areas that should be equity and timely access to care, preventive and clinical care, attachment. Every resident has the right Every newcomer has the right to be attached for an ongoing care. Culturally responsive, that Selimar said, outcome-based accountability, healthcare outcomes, productivity, not a dependency-based economy, but a productive-based economy. Newcomers can be burdened or newcomers can be productive. Depends on how we plan their settlement. And I told settlement is the healthcare issue, how we plan their healthy life. And finally, a cross-sector integration that is very critical. And thank you very much. In the second panel, we'll discuss about the co-design and together we'll work. This is the journey, beginning of the journey to work together. Thank you.